Hello, everyone, and greeting from Docplexus, and very warm welcome to all of you. I'm Shifa Sheikh from Docplexus. As we all know, Docplexus is one of the India's most trusted and leading digital platform dedicated exclusively for doctors, focused on enabling continuous medical education and professional networking. So, dear users, we are very excited to inform you that we have launched our new and updated version of Docplexus application where you can easily download the application from Google Play Store and App Store and stay updated with latest notifications, important CME sessions, and learning opportunity at all your fingertips. So I am requesting you to please download the application today for a smoother and enhanced learning experience. So for today, I am delighted to welcome you all for one of the very interesting session in ophthalmology, that is gene therapy for inherited retinal degenerations, where we are. As we might be aware, inherited retinal degenerations are a diverse group of genetic disorder characterized by progressive dysfunctions and loss of photoreceptor cells, often leading to severe visual impairment and blindness. Traditionally, management has been largely supportive with limited options to alter disease progression. However, advances in molecular genetic and gene delivery technology have transformed the therapeutic landscape. Gene therapy has emerged as promising approach aimed at correcting or compensating for underlying genetic defect responsible for retinal degeneration. With the approval of the first retinal gene therapy and several ongoing clinical trials, the field is rapidly evolving. This discussion will explore the current status of gene therapy for inherited retinal degenerations, key clinical success, ongoing challenges, and future direction for restoring and preserving visions. So it's my absolute pleasure to introduce our esteemed speaker for today's discussion, Dr. S. Natarajan. Dr. S. Natarajan is renowned ophthalmologist and Padma Shri awardee, recognized for his lifelong dedication to restoring vision and advancing eye care. With over 36 years of experience, he has performed more than 65,000 exclusive vitreoretinal surgeries, and he has also trained over 68 vitreoretinal surgeons globally, contributing significantly to the field. Dr. Natarajan is especially noted for his humanitarian work, including performing over 200 complex surgeries for palate injuries patients in Jammu and Kashmir, where he has also completed a remarkable 47 surgeries continuously within 2.5 days. In recognition of his meritorious public service, the government of Jammu and Kashmir honored him with a state award. So, without further delay, I would like to hand over the sessions to Dr. Natarajan. Over to you, sir.
Thank you very much. Thanks, Docplexus, for this opportunity. So I'll share my screen. You can see my screen?
Yes, sir.
Okay, so the topic is gene therapy. Where are we? And unfortunately, the most number of inherited retinal degeneration in the world are in India because of the history of consanguineous marriage in the past. So the common retinal dystrophies we see is diffuse photoreceptor dystrophy. Most common is retinitis pigmentosa. Then comes the Leber's congenital amaurosis and cone dystrophies. And the other macular dystrophies are Stargardt dystrophy, Vitiligo dystrophy, familial drusen, pattern dystrophy, Sorsby macular dystrophy. So history of gene therapy, the work is going on since the 1940s. Nucleic acids were identified as the carriers of genetic information, and 1960s method using bacteriophage virus developed for developing therapeutic genes to patients, and 1970s recombinant DNA technology, and 1990 the first gene therapy clinical trial approved for children with severe combined immunodeficiency. So why eye is suitable for gene therapy? More than 200 genes are responsible for inherited retinal diseases. Easy access to the site requiring the gene via an injection, and partial shield from immune system assures reduced risk of destruction of vector virus carrying the therapy. And how retinal gene therapy works. The vertebrate neural retina contains many different types of cells like retinal ganglion cells, rod and cone photoreceptor, etc. In retinal gene therapy, adeno-associated virus enters these various types of cells and expresses the DNA sequence of intended therapeutic value. So in our clinic, we have named the genetic clinic in Aditya Jyoti Hospital as Professor Dr. N.S. Sundaram Genetic Eye Clinic in the memory of my father, because he started the genetic eye clinic in Government Eye Hospital in Egmore in 1984 in Chennai, in Madras now. And so we always take a detailed history, a detailed family history, like a pedigree chart, comprehensive ophthalmic evaluation, genetic counseling, consent, and collection of blood sample for genetic study. So comprehensive ophthalmological evaluation, visual acuity, refraction and radical retinoscopy, effect of lenses, prisms, or occlusion on visual functioning, tonometry, central versus peripheral, visual field defects, and confrontation visual field testing, ocular motility and binocular vision assessment, Amsler grid test, and ocular health assessment with slit-lamp biomicroscopy. Central and peripheral fundus examination with dilatation, optical chromatography, fundus photography, and autofluorescence. We also do contrast sensitivity testing, glare testing, and in selected patients, the following electrodiagnostics like visually evoked potentials, electroretinogram, electrooptonogram, and color vision testing. So color blindness, recent research has found out that AAV can successfully treat color blindness in adult monkeys. And juvenile retinoschisis, X-linked recessive degenerative disease of the central macula, mutation in the RSI gene, encoding the protein retinoschisin, important for maintaining the synaptic integrity of the retina. The AAV5 vector containing the wild type human RSI, the cDNA, driven by a mouse opsin promoter, showed long-term retinal functional and structural recovery and improvement in the retinal structural reliability. So this is a fundus photograph showing a X-linked juvenile retinoschisis and foveal cyst. And retinitis pigmentosa is the most common inherited disease. It's present as a autosomal recessive disease, autosomal dominant or X-linked type. At birth, RP patients are born with dysfunctional rod cells, blind at nighttime in dim light. And after that, cone cells death occur, which are responsible for color vision, and acuity leads to full blindness in children. And if the mutation in RP is unknown, the gene replacement therapy cannot be administered accurately. So that's what we are all working in India. First, we are creating a database of segregating the various types of RP, because you have to know the exact gene before. And that's where the problem is, because as of today, there is no successful treatment. But one day it will come, but we have to be ready with the genotype and phenotype. Since apoptosis can be the cause of photoreceptor death in most of the retinal dystrophies, survival factors and anti-apoptic reagents can be alternative treatment. The rod-derived cone viability factor promoted the survival of cone activity and prevent progression of the disease by increasing the actual function of the cones. And this is the fundus picture of optic disc with the retina with the optic disc and waxy disc with the pigmentation all over like a bone spicules called the retinitis pigmentosa. And retinitis pigmentosa, the RDH11 syndrome, the defective genes are RDH11. And RDH is the retinal dehydrogenase 11. And so the rhodopsin, the light receptor, is formed by the combination of opsin, a protein, and a cis retinal. And RDH11 gene product is one of the forms of retinol dehydrogenase needed for the final step in making 11 cis retinal form, say 11 cis retinol. And this is a normal photoreceptor cell, and that's a mutated photoreceptor cell. Mutation of the RDH11 gene results in decreased ability to make cis retinal following for photoreceptor. This defect results in form of retinitis pigmentosa. Patients have night vision problems and cataracts in childhood. Systemic effects include developmental delays and cognitive defects due to altered retinal metabolism in other cells. The retinal degeneration, inherited eye disease, characterized by irreversible photoreceptor loss, The activation of the resident microglia is secondary to the disease. Stem cell-based therapy has recently made progress in treating the retinal degeneration. It has been demonstrated that transplanted neural stem cells in the retina exerted immunomodulatory effects on microglia, thus delaying the degeneration of photoreceptors. Few approaches are prevent disease by inserting a gene into patient's cells instead of using drugs or surgery. Replacing a mutated gene that causes disease with a healthy copy of the gene, inactivating or knocking out a mutated gene that is functioning improperly. Introducing a new gene into the body to help fight a disease. So the viral vectors are used for gene transfer. You can see a natural virus, insert a therapeutic gene, remove genes for viral replication, and infect and deliver therapeutic target to the target cells. And the most common method to deliver viral vectors to the cells is the intravitreal injection, targeting retinal ganglion cells and a few Muller glial cells. Subretinal injection, which needs vitreoretinal surgery to enter the subretinal space, targeting the photoreceptors and RPE cells, and access also from the suprachoroidal space. AVV as a vector for gene therapy, advantages, minimal immune responses, capability to mediate long-term transgene expression in a variety of retinal cell types. AAV serotype 2 initially used and 8, the new variant, have increased efficiency of gene transfer process. Generally, subretinal AAV is more efficient than the intravitreal route because the subretinal route may be subject to a greater degree of immune privilege compared to the intravitreal route. The viruses as vector, active clinical gene replacement trials are targeting Stargardt disease, Usher syndrome, retinitis pigmentosa, X-linked retinoschisis, choroidermia, achromatopsia, and Leber congenital amaurosis 2. And these trials use either adeno-associated virus or lentivirus as viral vectors. Luxturna is the new treatment where the first gene therapy, which is approved by the FDA, and here seeing the light thanks to the gene therapy. A Seattle man is the first adult to get a new gene therapy treatment called Luxturna to combat an inherited form of vision loss. In the procedure, which is expected to slow his vision loss but not reverse existing damage, viruses carrying healthy genes are injected into the retina. This is a syringe with viruses carrying healthy gene. So we have to do a vitreoretinal surgery and use a subretinal cannula and then inject into the subretinal space. And you can see the various layers of the retina with the ganglion cell layer, photoreceptor layer, bipolar cell layer, retinal pigment epithelium, and the cells after the injection can return to normal function. So here the gene therapy trials for various retinal dystrophies, LCA and retinitis pigmentosa, the RP65 gene. It's a phase 3 clinical trial sponsored by the company Spark Therapeutics. Choroidermia is again a phase 1 and 2. It is a Spark therapy. It's also done by University of Oxford and Night Star and SGZ eye trial. Excellent pigmentosa is a RPGR, and the sponsor are AGTC, Night Star, and Myra GTX. Stargardt disease, ABCA4 gene, and Sanofi is the sponsor. And Usher syndrome type 1, Sanofi, and achromatopsia, the CNGA3, the sponsors are AGTC, STZ, eye trial. Achromatopsia, CNGB3, again, sponsors are AGTC and NEI and Myra GTX. X-linked retinoschisis, NEI and AGTC. Retinitis pigmentosa, the gene MERTK. King Khalid Eye Specialist Hospital. Retinitis optogenetics, CHR2 gene. Allergan is the sponsor. And LCA ProQR is the CEP290 gene.
Choroidermia is a rare genetic disease in which photoreceptors in the retina and underlying vascular layer, known as the choroid, degenerate. Degeneration of the retina and choroid begins during childhood and develops into blindness in old age. Choroidermia is caused by a defective CHM gene. In the gene therapy, A functional copy of the gene is inserted into a virus vector. The vector is then used to deliver the gene to the degenerating photoreceptors in the retina.
This is a diagrammatic way showing the
6 of the 9 patients enrolled in the therapy trial have reported improved vision 6 months following treatment.
The first 6 patients treated at the Oxford Eye Hospital were all able to see better in dim light. In 2, the effects have been described as dramatic. The scientists first modified a harmless virus to carry a working copy of a human gene that sufferers lack. They then used a fine needle to reach the back of the eye, where they inject the virus behind the retina. The virus then infected light-sensitive cells, releasing the gene, which started producing protein that helped to preserve vision.
Rather than taking a pill or proteins or taking tablets, we're actually correcting the disease at a genetic level. In other words, genetically modifying the patients who have the problem to put the gene back that's missing. Obviously, we're very excited because potentially gene replacement is a way of stopping the disease from starting in the first place. And we could genetically modify people to prevent them from getting the disease and hopefully prevent them from losing their sight.
Around 1,000 people in Britain suffer from choroideremia, but the same technique could treat far more common genetic causes of blindness, including age-related macular degeneration. Doctors are so excited by the results published in the Lancet Medical Journal that they've already started another trial. The procedure could be approved for more widespread use in as little as 5 years. Thomas Moore, Sky News.
So this is a vitreoretinal setup where you do the vitreoretinal surgery and inject the subretinal. So in summary, vision loss from inherited retinal disease is a debilitating condition. Genotyping is the key to developing possible gene-based therapy. That's what we are working in India. As of today, India does not have gene therapy. Hope to get the gene therapy from abroad to India. And many gene therapies are under the pipeline and hope for the patient. Recombinant AAV and lentivirus can be engineered specifically as a vector. So this domain still remains in the vitreoretinal surgeon's domain, where we have to do an advanced vitreoretinal surgery. As you saw the operation theater setup, we have to do that and inject the vector in the subretinal space, and then the patient should be treated. So the main target for ocular gene therapy involves the retinal pigment epithelium or photoreceptor, and the most common method to deliver vectors, viral vectors to these cells includes intravitreal injection, subretinal injection, or the access from the suprachoroidal space. As of now, doing a vitreoretinal surgery and subretinal injection seems to be the best so that you can get the best results for the patient. So these are the references for the talk today. And so the main thing is, thank you very much for the patient listening.
Yes, sir. Thank you so much, sir, for your wonderful and in detail talk on such an important topic.
Right.
So, sir, I just wanted to ask 2 questions from audience perspective.
Right.
So, the first question is that, sir, as per your experience, still, what are the biggest challenge clinicians are facing when identifying suitable candidates for gene therapy, as per your point of view, sir?
Right now in India, since there's no treatment, patients are not ready getting the blood test done for genetic testing, that is genotyping. So we are doing a phenotype. That means we take the retina photograph, ERG, EOG, and pedigree, but we have to match it with the gene diagnosis. So that only patients, where you have to pay money for the genetic testing, and patients are saying, by doing the test, what is the benefit now? As of today, there's no treatment. The treatments are emerging, and it's only a clinical trial going on abroad. So one is to recruit the patient. And second, if you see that many treatment is aimed at maintaining the vision and reducing further loss. So people expect a dramatic improvement. So that's another challenge to make them understand the real outcome of surgery and what they should expect. And then they have to be realistic, and those patient selections are important. And that's the challenge as of now.
So thank you so much, sir. And the next questions I would like to ask, is there any specific genetic mutations that remain particularly difficult to target with current technologies as well?
No, the problem is there are multiple genes. Each, particularly these, they are all monogene disorders. That means one gene is involved. But to get a gene therapy, right now that Luxturna is there for RP. Then they are trying for choroideremia. Then they are trying for Stargardt's disease. So like that, only few we are able to break it using the gene therapy. There are hundreds of genes which has to be identified where we can do a gene therapy, like either delete or modify the function of the existing mutated gene.
Yeah, that's great, sir. And one last question I would like to ask, sir, what we have learned from ongoing clinical trials regarding the long-term safety and efficacy for retinal gene therapies.
So the long-term safety has been proved in the phase 1 and phase 2 and now in phase 3 trial. But the main thing is about expense. And this Luxturna, which is made by Spark Therapeutics, and Novartis is marketing, and it's costing about 4 crore rupees for one eye. So that means $400,000. So for one eye, so that is one inhibition. And second, this can be only used for RP65 mutation and not for the other retinal degenerations.
Yeah. So thank you so much, sir, for answering all the questions. So let's conclude the sessions.
Yeah.
On behalf of entire Docplexus team and on behalf of entire our audience, we really thanks Dr. Natarajan for sharing your valuable insights in deep clinical practice on experience on such an important topic in ophthalmology, that is gene therapy for inherited retinal degeneration. So your session has truly helped bridge the gap between technology and clinical practice. And we also thanks to all our participants for joining us today, for your active engagement throughout the session. And we hope you found the discussion very informative and clinically relevant. So on behalf of Docplexus, we look forward to welcoming you all for our upcoming educational program. So till then, have a great day ahead, all of you. Thank you so much, sir. We are looking forward for many more.
Thank you, sure.
Thank you.
Yeah.